Good afternoon. Good afternoon. Thank you. Pleased to welcome you all, and thank you for joining us today. The School of Public Health's Opium series is really intended to provide a forum for speakers and for discussion in addressing some of today's most pressing public health problems and concerns. It's my privilege to welcome and introduce our speaker for today's colloquium, Dr. John Howard. Dr. Howard is the director of the National Institute for Occupational Safety and Health. He also serves as the administrator of the World Trade Center Health Program within the U.S. Department of Health and Human Services. Dr. Howard first served as NIOSH director from 2002 to 2008. Then took a brief hiatus to Afghanistan, I understand, and returned in 2009 and has served as NIOSH director since that time. He received his Doctor of Medicine from Loyola University in Chicago, his Master's in Public Health from the Harvard School of Public Health, his Doctorate in Law from the University of California at Los Angeles, and his Master's in Law and Administrative Law and Master's in Business Administration and Healthcare Management from George Washington University. He is board certified in both internal medicine and occupational medicine, and also serves on the faculty of the Milton School of Public Health at George Washington University. In addition to joining us here this afternoon, Dr. Howard is also here to launch NIOSH's 7th Annual National Occupational Injury Research Symposium, which begins tomorrow at 8:30 at Morgantown Marriott Waterfront Place. So I hope that some of you will have an opportunity to also spend quite a bit of time this next week down at the National Occupational Injury Research Symposium. I'm pleased that Dr. Howard was able to provide us with some time today to provide his insights on the current opioid epidemic in this nation and its impact on the nation's workforce. So please help me and provide us a very warm Mountain Dew welcome to Dr. John Howard.
Thank you very much. Everybody can hear me in the back? Yeah, wave, yeah, shout, something. Thank you. Thumbs up. Great. So I just want to get credit for coming to talk about opioids in West Virginia. Okay. I think I deserve extra credit for that. So what I want to do today is give you a very comprehensive view, which means that I will spend little time on any one topic. So if you want the slides, I have lots of references at the end you can avail yourself of. So I thought we'd talk about some terms and some medical toxicology, not a lot. Drugs through American history, because it's a fun historical topic from a sociological perspective. Any sociologists in the audience? Excellent. So, this is a very interesting country we live in, and we'll find that America has a particular relationship with drugs that really is not shared by other countries. The current epidemic that we're in right now, and a little bit about how the hell did we get into this mess, which is always a question people ask. I have no idea the answer, but there's a number of really good papers on this issue that we'll cover. And what's work got to do with it? Obviously, I work at a place in which work is a very important issue. We study how work is done and the various issues associated with work. A little bit about the various interventions that are out there. And then at the end, a little sort of coda about a particular type of opioid and its relationship to the people that all of us depend on for our safety and health, first responders. So this is the beautiful opium poppy and the little sap coming out of there. You wouldn't think that that could cause that much of a problem. This is the milk of paradise. It's a new book that's coming out written by an historian in England, and it's not out yet, but she traces our 10,000-year history with that sap that's coming out of that beautiful plant. I encourage you not to plant this in your yard. DEA has drones now. So, you know, there's a lot of confusion about the terminology. And so I wanted to clarify the difference between an opiate and an opioid, because there's a lot of confusion. And opiate is really that sap and the stuff that you can make from the sap, and not really synthesize it, but just, you know, extract it from the sap. And then an opioid is a larger world of drugs that you can, you know, go to the lab and have fun with and create all sorts of other things, attach a hydroxyl group here, you know. So by the time we get through, then we have this sort of tripod of opioids. The first are the natural ones. You take the sap, and you can make morphine out of it, morphia. We'll see how that was a very popular thing in the 19th and 20th centuries. Then you can do some little manipulation, and you can be a drug company that can create hydrocodone or oxycodone. Okay, they're semi-synthetic. Or you can develop something that's totally synthetic, came out of the lab, nowhere near the poppy sap. Okay. And those are called synthetic opioids. Methadone, Demerol, Tramadol, fentanyl, and carfentanil. Those are the two that we'll talk about at the end. Those are purely synthetic opioids. So that is the world of opioids. That's the term that we use, unless we're referring to a specific sap-extracted drug, and that would be an opiate. Okay. So the way these drugs act from a pathophysiological standpoint is, as everybody knows from basic chemistry, the receptor determines the effect. So if the chemical binds to the receptor, then out comes the effect. So essentially, opioids increase activity at a number of different receptors that are found in the body, chiefly the Mu receptor. Now, these receptors respond to both endogenous. Anybody give me an example of endogenous drug, that the opioid that the Mu receptor responds to? Endorphins. They're floating around, or exercise, etc. The happy feeling that we get from doing that. That's a Mu-related receptor phenomenon from an endogenous and exogenous, an opioid. Mu receptors responsible for most of the clinical effects, and they're concentrated in certain areas that we'll see. But they have two major effects: analgesia, pain relief, and then the euphoria, the pleasure. That is a very powerful combination. To relieve pain and make you happy, I mean, come on, really. And the rewarding effects, we'll see, are most significant when the drug can be delivered as rapidly as possible to those receptors. So insufflating it or snorting it up your nose, heating a fentanyl patch that's not even designed for that. It's fast work. So the faster you can get the drug to the opioid, the more significant the euphorogenic effect can be. So where are these receptors? And they're in a lot of different places, but chiefly they're in the brain. And they're in the brain where all the pain centers are, and unfortunately, they're in the brainstem there, which houses the respiratory center that makes the phrenic nerve push the bellows up and down, okay? Not a good place to have Mu receptors, but they're there. They're also in the spinal cord, the peripheral nervous system, and they're in the small intestine that regulate gut motility. Anybody ever take on Imodium or a Lomotil? We're all opioid users, okay, in this country, okay? Dose is a little different, obviously, but that's how we stop diarrhea from happening. So these are where all the receptors are. Clearly, the worst place the receptors are in the brainstem, in the breathing center. Now, just a little bit about toxicokinetics, because when you go to the pharmacopoeia and you look at toxicokinetics for the drug, and the manufacturer at Janssen or Purdue Pharma tells you about how this drug works and everything, it has nothing to do with the way people are actually using it that are abusing it, okay? It's a totally different world. So if they're cramming a whole bunch of tablets down their stomach, you know, they're delaying gastric emptying, decreased motility, prolongs the absorption. That's not the way the manufacturer said you should be taking this drug, Okay? So the effects that we see in an opioid use disorder, you can't really open up the pharmacology books and see that they make any sense. And there's just a little bit about the saturation issue here. Not to belabor this too much, but clearly, you know, when you put that much of the drug in, the first-order eliminations end up getting overwhelmed. And you have a big toxicokinetic problem. And then these high concentrations in the body, you don't have to add too much more. Just a small increase. And that person that was upright, sitting, talking to you is now on the ground and blue. Okay? Because of that small increase, that little extra dose they took, etc. So these are toxicokinetic effects that have to do with this whole different world of abuse, not the way the manufacturer intends the drug to be used. Okay, and so that's an important issue when you look at what's going on in an individual that has abuse issues. Now, I think we all know this. The essential sign of an opioid overdose is somebody becomes apneic or their breathing slows. And so most medical toxicologists would just say, look, if somebody's not asleep and their breathing is below 12 and 10 and 8, and you know, there's something wrong here, okay? And they probably are experiencing some kind of respiratory depressive effects. That suggests acute opioid toxicity. You throw in the little narrow eyes, which a lot of people never get. It's classically described. Also, they're stuporous. They really aren't making any sense, or they're out, whatever. So the three of them, the respiratory depression, the meiosis, and the stupor, okay. That's classic, okay. And you see it in people who have clear, classic medical toxicological overdose. But you don't necessarily see it in somebody who may be exposed to a little fentanyl. You're not going to see them on the ground, okay? Maybe briefly, but they're not going to be out. You don't have to see these kind of classic situations. You look at a medical toxicology book, this is all you see. You do not see described a non-fatal overdose situation. In fact, we have a very hard time collecting statistics on non-fatal. Okay, so I wanted to contrast the classic toxicological clinical manifestation of an overdose with what we're going to see in a responder who may be feeling not so well after maybe being exposed to fentanyl. The two are entirely different. So it's not just the respiratory depression, the meiosis, the stupor. There's lots of other things that can happen, including rhabdomyolysis and all sorts of terrible. So you have somebody come in the emergency room who's been in an overdose situation for a prolonged period of time, etc. There can be lots of other clinical manifestations. I wanted to point out, though, this incentive that people have a lot of trouble in the United States separating out from a sociological perspective. These are people that, you know, they're drug addicts and they're just seeking pleasure all the time and personal responsibility, all this other stuff. When in fact, when you think about and you talk to people who are addicted, who have opioid use disorder, they will tell you that their drug-seeking behavior is less about getting that wonderful feeling than avoiding being dopesick. Okay, this is the title of a new book by Beth Lacey, who is a reporter from the Roanoke Times. I encourage you to read it. It's about Western Virginia, around Roanoke, etc., and all of the situation going on there. But this idea of trying to avoid being dopesick is a stronger motivation that people have than actually seeking the euphorogenic aspects of the drug. And these words don't mean anything to anybody unless they all come together in your body at the same time. It's a terrible, terrible, terrible thing. So let's talk about the fun that we've had in this country with drugs. And there's no end to it. It's still going on. And it started a long time ago. So here we are. These are Civil War veterans, injured in the Civil War, etc. And in the decades after the Civil War, you know, we really got into morphine in a heavy, heavy way. And in fact, I say genteel society ladies. I don't think there's any such thing anymore, but I don't think the Kardashians would be genteel. But anyway, they were using laudanum which is this tincture of alcohol and opium. And there were all these kinds of syrups and tinctures and all this stuff going on during that time. And this example, this is Mrs. Winslow's soothing syrup for children. And, you know, kid had diarrhea, let's give him some Mrs. Wilson's, you know, syrup. Takes care of the diarrhea. Well, unfortunately, you know, this was good until the kids started dying because they were overdosing. And nobody knew what an opioid overdose was, and how could Mrs. Winslow's soothing syrup for children be causing this problem? But clearly, it was a big problem. So it got so bad that around the turn of the last century, the president said, you know, we have to get this together. And he put together a delegation go to the International Opium Conference at The Hague in 1911, okay? And we're more than a century beyond that, okay? And we're still in the opioid mess, okay? So this is the commissioner. This is America's first opium commissioner, Hamilton Wright. There's a physician from Ohio, and that was part of the U.S. delegation that went to The Hague in 1911. So that sort of kicked off and was in the middle of this effort by government. We're going to stamp this thing out and take care of this problem. So in 1890 is the first sort of taxing of opium. We'll tax it. That's always the government's first response. Let's tax it, and then people won't buy it. You know, cigarettes, tax, you know, always a very good thing. So, okay, so we'll tax it. Didn't seem to help. So in 2006, the Pure Food and Drug Act forced manufacturers to disclose what's in the product, in Mrs. Winslow's soothing syrup. So mothers would know that they're giving their kids opioids. And then in 1909, Congress passed the Opium Exclusion Act, which banned the importation of opium for smoking only, you know, because that was that China thing going on at the same time, you know, opium dens, all that sort of thing. So then in 1914 came the Harrison Tax Act, and these actually were guys that the Treasury Department sent out to pharmacies. See, there's two guys going through, throwing the syrup into the trash can and all that. And then they get this, you know, special little thing here. So that essentially led us to 1970 and the Nixon administration. And we're still in 1970 world now with the Controlled Substances Act. Okay, that's the legal paradigm that we're in. Passed by the Congress, created 5 schedules, and we can just quickly go to those 5 schedules. This is still a big problem in the United States because we have, as you notice, the DEA Schedule 1. There's that word marijuana over there, right? And the state I'm from in California, the district in which I live, the District of Columbia, marijuana is not a bad thing, you know, not a bad thing, either medically or recreationally. And up here, I, as a physician, can't even prescribe it because it's a Schedule 1 drug. It has no medical indications. Now we have that federal-state thing going on, okay? So you can see morphine. I can prescribe morphine, codeine, methadone, Demerol. Well, not methadone, because that's restricted by physicians. So we'll get into that. So these other sort of wars on drugs in the United States, I think we need to understand the history, because otherwise, if we don't understand the history, we're going to end up sort of repeating these things. So in the 50s, you know, speed freaks, amphetamines, you know, all that was very popular. 60s and 70s, we had Vietnam veterans. We had a big heroin problem going on there. In the 1970s, cocaine, especially the crack, the cheapy one, Richard Pryor and all that. We had the crack thing going on. So don't forget that this isn't new in the United States, okay? There's a long history. So now we're in the 21st century with opioids. You've all seen these kinds of graphs. They're all going like this, you know? So you don't have to be a fancy epidemiologist to understand the word epidemic when you start looking at those curves, do you? I mean, I don't see how you can even have a graph that has a straight line. So, I mean, this is about as straight line upwards as you could possibly see here, where we have synthetic opioids other than methadone, okay, in terms of overdose deaths from 99 to 2017 at 29,000, and then some of these other ones. So these curves are really shocking. And of course, you know, here we are. Is this a problem widespread in the United States, or is it localized? Well, you know, you can look at the age-adjusted drug overdose deaths per 100,000 from CDC data just released, and you can see that the state, we're talking about 52 deaths per 100,000. There's, what, 2 million people in West Virginia? Do the multiplication, you know, it's quite a bit of people. Kentucky, and actually Ohio, Pennsylvania, New Hampshire, Maine, Massachusetts, the District of Columbia. We see that it's not distributed uniformly. And what's very interesting about this versus, you know, that sort of heroin skid row thing, you know, that we always think, you know, heroin skid row, urban areas, you know, SVU, you know, that kind of stuff. It's interesting that this epidemic, though, is different because it's affecting rural areas more than the urban areas. So again, it's different. It's not across the United States totally, and it certainly is more rural than metropolitan. Now, you say, oh, well, I'm sure that we're not the only country suffering from this kind of thing. I'm sure we could look to other countries and see what kind of solutions they have. Well, you know, unfortunately, we take about 80% of the world's supply of opioid drugs, just are in the United States alone. So that only leaves the rest of the world about 20%. 90% of the supply of morphine, fentanyl, and oxycodone was used in the United States, Canada, Australia, and New Zealand in just 1 year, 2009. And that same year, the United States consumed 83, 99% of the world's oxycodone and hydrocodone, respectively. So we can't exactly say this is an international experience. In fact, we look at these other countries in terms of the deaths from drug poisoning and those caused by drug-related mental disorders like suicide, and you see that there's no one even close to us. So it's not like this is some kind of international thing that affects the human race. You know, an equal opportunity killer like Ebola or influenza or something like that. And in fact, when you start looking at the literature in great detail, and this is from the famous paper that Case and Deaton, Angus Deaton, who won the Nobel Prize in Economics in 2009 or 10, I can't remember. This paper appeared in the Wall Street Journal, New York Times, and everywhere else, and I'm sure that if you really want to read about it, it's in the Proceedings of the National Academy of Sciences. Well, he first pointed out, look, this isn't even, you know, proportionate across ethnicities. It seems to, this thing has seemed to be affecting this idea of U.S. mortality, white Caucasian males, rather than other populations. Here's the U.S. in comparison to other countries. And you can see that when you look further at the mortality figures, other than a little kind of flattening of the chronic disease, maybe lung cancer is way down, suicides, these are accidental poisonings, the red line. So it seems to be the cause of why U.S. life expectancy is going the other way. So you can see from this chart that the United States is going dipping down. All the other developed countries are continue to have increased life expectancy. And the U.S. Is seen as having decreased life expectancy. So in December of last year, CDC confirmed that the life expectancy for U.S. decreased for the second year in a row. And they have data that will come out this year that will show that it's even a third year in a row. And what's fascinating and important for us to realize is these aren't, you know, a bunch of people in Boca Raton who are in their late 80s deciding to, you know, take opioids and develop overdoses and die. These are people in the prime age of the working relationship. This is a very interesting slice. Although they caused just 6% of deaths in 2016, they're claiming people in the prime of their life, a very different kind of epidemic. So when we look at the causes, and we could spend another couple hours talking about this, I just wanted to mention two: proliferate prescribing, which we're putting a lot of effort in, and predatory promotion, and then all of this other stuff. You know, we've had a bunch of psychologists in this room. They'll say, oh, you know, there's a lot of psychological issues. Incarceration in the United States, a very high level, but we don't treat while somebody's in prison. And you go to any prison in any state in the United States and you'll find opioids. Economic dislocation is a serious cause. Unemployment, no jobs, bad jobs, injured workers, etc. Especially in West Virginia. Genetics, maybe there's genetic, and lots of other causes. So let's just talk about this Oxycontin thing, which really is the prescribing issue, because you write a prescription for that. Can't write a prescription for heroin, can't write a prescription for other things. So, you know, first came into the U.S. in 1939, approved by FDA in 1995. Purdue Pharma began making and pushing it during that time. Bayer makes the little aspirin thing. They actually were making heroin up until the turn of the 20th century. They stopped doing that, and there was a big gap in terms of pain relief. Now, this is sort of a rapid history, from my point of view, of where the prescribing part of the epidemic came from. So, in '96, the American Pain Society said, you know, you're measuring respirations and blood pressure, and there's a fifth vital sign you should be measuring: pain, and we're not measuring that. And you physicians should be doing that, because a lot of people with chronic pain, you're not treating them. So patients were encouraged to screen, physicians were encouraged to screen their patients to treat, not cancer pain, which everybody knew had to be treated, but non-cancer pain. And what's the worst non-cancer pain that's the most prevalent in the United States? So it's really low back pain in workers, okay? Okay. So the drug companies then began educating physicians that opioids, especially the long-release ones, you know, could give you many hours of pain relief. And by the way, they weren't addictive, so you didn't need to worry about that. There was a famous letter in the New England Journal that's, you know, quoted and all that. That probably was false. Probably false. Maybe not intentionally, you know, false, but it was probably false. Because they had only had the Oxycontin out for a short period of time. So then prescription opioid use increased. Because in medicine you learn the thing that pushes the product, the device, the drug is if CMS, the Centers for Medicaid and Medicare Services, will reimburse you for it, okay? Things that you can't get reimbursement for are not prescribed and are not used, okay? So that created a big financial incentive. And then all this made opioids, and especially Oxycontin, the go-to drug. Okay. So you have this whole issue going on about Purdue Pharma. Were they predatory, and did they try to push it? And it resulted in a $1 billion in 2000. After their $1 billion they made by 2007, the executives pleaded guilty, and they had to pay a big. It's still going on. States' attorney generals are still suing Purdue Pharma. So there's a lot of litigation issues going on. Okay, so, you know, the issue for us at NIOSH is, you know, okay, so what does work have to do with all of this? So this is, and I don't know whether Dr. Sullivan is still here at WVU. Is he still here? Yes?
Just
no?
retired.
He retired. Anyway, I found this quote that he did several years ago when he was talking about the relationship of opioids in West Virginia to work. And I thought it was particularly interesting. And when you look at, this is a county map in terms of opioid overdoses, you can see this area involving 3 states just in this particular area, primarily Southern Virginia. Now, since that time, where there was no data at all, we have seen some data come out about the relationship of work to opioid use. And I really encourage you, if you're interested in this area, this is a paper that came out from the folks at the health department in the state of Massachusetts, looking at a very small 4-year period of time, 2011, 2015. And as we'll see, they saw that opioid deaths were not uniformly distributed across all types of workers and industry. They actually ended up in some very specific types. And that it was rather a whopping difference. 6 times the average rate for all of Massachusetts workers tended to be in these specific categories of construction and extractive industries. And they accounted for more than 24% of all deaths. So when you look at some of their data, here's all workers in Massachusetts here. And here's construction, agriculture, forestry, and fishing, and then as you go down. So these are opioid-related overdose deaths by industry sector. And when you look at occupations, you see the same sort of thing where you have construction and extractive industries. What's also interesting in this paper is they looked at opioid-related overdose death per 100,000, and then they stratified it by the number of injuries primarily, but illnesses, which are much harder to count, so it's primarily just injuries, per 100 full-time workers, okay? So you have this rather interesting dose response that the more you get injured in your workplace, the more likely you are to die of an opioid death. And we see that that really is because you end up either waiting for your workers' comp claim to be adjudicated, and you're in horrible pain, and you're probably going out and getting an illicit supply of opioids, or you're in and your claim's been accepted, and you're in the medical workers' comp system, and you're getting opioids prescribed to you. So these papers, and there's a bunch of more on this issue of this relationship in the workers' comp. And I wanted to show you this from the Workers' Compensation Insurance Institute in Boston. And this is a comparison between the average sort of morphine equivalent amounts that are in the, and these are per claim, okay? So, you know, there's people that get 4,000 morphine equivalent amounts per claim, per low back pain claim. So what they tried to show is, based on these states, the changes between 10 and 15, let's say. So you see New York, in New York and Louisiana, people are getting a whole lot of opioids per claim, per their low back pain claim. But New York has done a good job because the yellow shows the reduction. So all of these states have seen reductions. Here, Wisconsin, Indiana hasn't seen too much. But that's another example of the worker comp. Here's another study from AIS looking at medical data service between 12 and 15, and you can see that there's some decrease. The workers' compensation system is responding as other parts of the country. So let's talk about a few interventions: prescribing, public health measures, overdose reversal, treatments for opioid addiction, and interdiction itself. So, you know, the whole thrust that public health agencies can do now is sort of rectify this cause relating to prescribing. You know, what is inappropriate prescribing, what is appropriate prescribing. And what's really fascinating is a public health agency like CDC telling doctors and nurse practitioners and others, here's what you should be doing. A public health agency is telling rescue medicine people, a preventive health agency is telling rescue medicine people, here's what you should be doing. Fascinating when you think about it. Those kinds of things usually come from rescue medicine societies themselves. The American Society of Gastroenterology, the American Cardiology. They tell cardiologists what to do. But it's a fascinating thing now that we're seeing that the Centers for Disease Control is saying, look, you need to monitor these people that you're giving opioids to. And we also see that if they're consuming doses of alcohol, if they're using benzodiazepines, if they're not adhering to, you've got a problem there. And so when you look on the CDC website and you see things like this, where you can stratify the risk of having an opioid overdose by your morphine milligram equivalents per day, and say that once you get more than 20, morphine milligram equivalents per day, you start having, and dosages above 50 increase significantly. So you have a preventive medicine agency telling rescue medicine people, here's what you should be doing. Now, there's also other ways that governments are trying to do this, and professional societies too. And prescription drug monitoring programs are in every state, but I, as a physician, if I was practicing in West Virginia, have to sign up for it. There's some issues there. Fewer than 5 of these states require their use, so it's voluntary. And less than 20% of doctors are using the databases to go look up whether that particular patient that's asking for those opioids have them. Electronic prescribing is an idea that probably is better. What it does is take advantage of the fact that we're in the 21st century and we can take a pharmacy's computer and link it to a physician's database and to the patient so that we can link all three so we know who's getting what. So when that prescriber is looking up a patient, they look in the database and they can see the pharmacies. Every pharmacy has to participate that is dispensing an opioid. So the system is all connected digitally. Maine, Minnesota, and New York are requiring e-prescribing. There's a bill in Congress now, Every Prescription Conveyed Securely Act, which would apply only to CMS-funded pharmacies. So this hospital is funded by CMS, let's say, so they would have to do it. E-prescribing is not included in the 600-page opioid bill that was just passed by the Congress, but it is something that probably we're going to end up going to. Now, all this prescribing stuff is great. And you're starting to see, and I just heard this morning from my colleague who runs the injury center at CDC, that this blue curve, which is the prescription curve, and the red is the illicit curve, okay, that the prescribing part of the epidemic is responding, okay, and it's going down. But the illicit part is not. So is this like the toothpaste, thing where you squirt one end and it's coming out the other end? I don't know. So this is an interesting slide. This is from an MMW article that was just published recently. And this is the percentage of deaths by prescription opioids, illicit opioids, and both by state. And so the dark blue is your prescription epidemic. And then the lighter blue is your illicit epidemic, and then the real light blue is kind of both. Now, I don't know what the hell's going on in Oklahoma. They seem to have not gotten the message about the prescribing issue. But other states seem to have more of an illicit issue than a prescribing issue. And here's West Virginia, more of an illicit issue, kind of with a little higher than New Hampshire, which has a terrible problem, Massachusetts, so it's a little higher in West Virginia. New Mexico and Oklahoma clearly a little higher. So those are two different epidemics, I believe, and I think they have to be treated a little differently. So the public health measures are always controversial, and anybody who knows public health policy knows that you're walking into a buzzsaw, because an idea that seems perfectly reasonable to a public health person can look like the end of civilization to a politician, okay? This is the way it is. So we've had this idea of safe injection sites, which are very popular. The one in Vancouver, Canada has been going on for, I think, 12 or 14 years. I just talked to somebody from their center. They have seen marked decrease in the number of people that are asking for treatment when they come into the safe injection site. They've seen a decrease in their HIV and their hepatitis and all that other stuff. That's the other epidemics that come from the use of shared needles. And then there's drug testing stations in which you can come in and say, is this drug I'm about ready to take, does it have any fentanyl in it? Because, when I bought it, it was supposed to be, Oxycontin. Now, Rod Rosenstein, who is always in the news every day, wrote a nice op-ed piece in the New York Times August 27th, and he said, we don't cotton to this kind of stuff at the Department of Justice. We don't like that kind of thing, Now, there's an underlying sort of sociological issue that we'll get to when we talk about interventions in terms of medication, and that is abstinence better than maintaining somebody on a drug? Okay, and we'll get to that. But essentially, he's saying federal law says, no, 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 you can't do that. You cannot give out these drugs. You can't allow that to happen. It's illegal. You shouldn't be doing it. Now, it's an op-ed piece. Is it a shout across the bow for New York City, Philadelphia, San Francisco, Seattle, and other cities that are considering this kind of thing? Who knows? So, you know, there's a little bit that I wanted to mention about opioid reversal. Clearly, you know about Naloxone. It's used in hospital situations. Now, the Surgeon General wrote an advisory in April this year saying, look, if you're a family member and have somebody who has opioid, you probably should have Naloxone in your home, etc. We just put on our website on Thursday a fact sheet about the use of Naloxone in a workplace setting, if you're all interested in that. We have a number of prongs to that. I'll ignore the proposed fact sheet because it's actually printed now. But the big issue is the risk assessment that you have to do to decide whether you should have Naloxone available next to your AED or next to your first aid kit. And then, you know, how do you make it available? Who's going to do it? Train people? It's a very complicated thing. But if you're in an area in southern West Virginia where you're a librarian in a public library, you've had to call the paramedics for people that are using your bathrooms to overdose in, you know, maybe it's not a bad idea to have it in that workplace. So let's talk about medication-assisted treatment. Now remember, this is in juxtaposition to abstinence, okay? So we know about methadone. It's a full agonist. We're just substituting one opioid for another, okay? It hits the Mu receptor, clicks in, everything happens. It's a little less because it's not exactly the same. But then we have buprenorphine, which is a partial agonist. Generates just a limited effect. People can work while taking this, and they can get on with their lives, and they're not doing drug-seeking behavior, et cetera. And then we have naltrexone, which blocks the whole thing. It can cause a person to go into an opioid withdrawal and all that, so it's used. You have to be off your opioid, et cetera. But some abstinence programs will use naloxone. So there's a tension between these two types of approaches. And you can see what it is. So a lot of residency programs, and nobody's saying that medication-assisted treatment shouldn't be associated with behavioral therapy. And if you combine the two, the effectiveness of those folks staying off of opioids illicitly is significant. The United States federal government, SAMHSA, CDC, NIH, we're all saying that this is an effective way to treat people. But there's a tension between that kind of data and the abstinence folks who are running primarily residency programs, which say you're a substitute, we're going to get this person clean off of the drug altogether. The problem with medication-assisted treatment, there's a number of issues which the federal government, the Congress, which the President's going to sign, the bill will help in terms of more Medicaid providers, the increasing the number of addiction recovery specialists, getting insurers to cover it. Obviously, Medicaid is an example. And the problem of drug treatment centers that are primarily, these are abstinence leaders, rejecting that issue is a very powerful one and can affect their revenue. So this struggle is going on in the background. It's obviously a significant issue. I wanted to mention all the stuff that NIH is doing just to close this off here. Clearly, the Narcan nasal spray was actually invented with NIH researchers and a pharmaceutical partner. And now NIH is trying to find other modalities that stimulate the analgesic center, but not the euphorogenic center. Interdiction, you obviously know about. Lots of production in China. Going on. This is Rod, our friend again, saying that there's a number of traffickers that he's indicting in China. Let's talk about, to end this, fentanyl, which is a purely synthetic, very, very, very potent. In fact, it's so potent that sometimes administering naloxone can be too late, or sometimes even repeated doses of naloxone can be an issue. It's a Schedule II prescription drug. It's widely used post-surgically and for chronic cancer pain, et cetera. It comes in all sorts of formulations, including a lollipop, a patch, a pill, a liquid, an IM, et cetera. Some of you may remember the Moscow theater crisis, in which the Russians cleared Chechens out of this theater in Moscow by spraying probably fentanyl, carfentanil, maybe with another drug. 125 people died. And the British toxicologists grabbed some clothing from some of the survivors, and they found carfentanil and remifentanil, which is an analog of fentanyl. Clearly, seizures containing fentanyl coming from China are significant. I mean, that's just 1 year from 15 to 16. And you can buy on the internet, you can order your own pill press, and what you can do is sort of make Oxycontin, but you can throw some fentanyl in it too, which is that contamination issue people are concerned about. Clearly, the number of overdose deaths have gone way up with fentanyl alone. And there's lots of efforts. The president declared this whole thing to be a public health emergency, did a commission, and I wanted to point out one of the commission recommendations, which develop an outreach plan for fentanyl safety, and that's which is on our website, and there's our little logo at the end, which educates responders about issues associated with exposure to fentanyl. There's lots of recommendations that are available for folks, for first responders. And the recommendations, I think, it's something you may want to get into. I'm not going to get into them here. I wanted to point out our website on fentanyl and how we sort of qualitatively decide that there's exposure going on, either mild, moderate, or severe, and then we relate that just to the types of respiratory protection and dermal protection and hand protection. I wanted to point that out. Again, it's all on our website. We have done health hazard evaluations, or sort of investigations, where we go out when first responders have experienced ill health effects. Again, no responder has died. They haven't had a classic overdose, but they have experienced symptoms of lightheadedness, nausea. Some of them have passed out or gone down, at least, on the ground. And the question is, what's going on? It's very hard to do this retrospectively. But clearly, after this whole thing is over today, I think we can all conclude that we got a problem. And these rates are probably driven more by the illicit epidemic than by the prescribing epidemic. And clearly, a lot of supply-side and demand-side interventions have to be done. And it's not going to be over anytime soon because the root causes may be more sociological than medical. So thanks a lot. Happy to entertain any questions you guys have. And it's... Yes, sir.
Yeah, Gordon Smith, Department of Epidemiology. I'm interested to know if NIOSH has done, there's many studies that have been done looking at people who initially got addicted because of their back pain with the Oxycontin. And what we're seeing here now is a lot of people being thrown to the street because basically they're restricting the opioids and cutting people off without adequate availability of treatment. And to me, it's been really interesting to think about a study as to people that were on workers' comp rolls, but I've not seen anything. I'm wondering if you're aware of any studies where they've been able to follow up and then look at those who die of a drug overdose.
Well, certainly, first of all, your observation where the prescribing guidelines are sort of like a pendulum, over here and now we're way over there. So, I've talked to people and have talked to physicians. Physicians say, I'm really worried because I'm in a managed care situation. They're going to bad things are going to happen to me because I'm continuing to prescribe opioids to this patient that, that is slightly over the MMEs that are recommended, et cetera. The patients themselves are saying, I've been on this, I've got this surgically uncorrectable back issue or whatever, and I've been on this, or I have MS, or I have chronic endometriosis, and I've been on this for 12 years, and now they're saying they're cutting me in half. And, so this urge, this emergency urge to prescribe has gotten really too crazy, and somehow we're going to have to bring it back. The second part of your question is, no, I'm unaware of somebody putting together those kind of patients to figure out what's going to be their outcomes. Because ostensibly, being in chronic pain and severe chronic pain can have many physiological effects that you would not like to see, and could even shorten life, et cetera. And so the issue then is what's going to happen to these people. So we've gone kind of, crazy in this direction. And
the only way that Americans can do.
Yes, only Americans. It's sort of like, are you from Great Britain?
New Zealand.
Okay, well, anyway. So Churchill once said, Americans try everything first, and then they finally figure out what the right thing is in the end, yes, sir.
That actually leads into sort of my question. So I was interested in what is the rest of the world doing about pain. It does not seem like on-the-job injuries have to be a purely American phenomenon. And in that sort of context, how are we still justifying subjective pain scales as a qualitative evaluation of medical care?
Well, certainly, these are two great areas, two great questions. And I think, one, we can learn from how other countries are treating work-related injuries without opioids. And we can also learn a embryonic effort, and there are papers written now, where post-surgical pain relief is being effectively done with an NSAID and a Tylenol, for instance. And there are a couple of papers on that issue. So we're starting to learn that we can relieve pain, at least in the post-surgical area, where a lot of, you go have any kind of operation, the doctor says, here's 90 Vicodin and go home. Mainly because they don't want you to call back. And two, because that visit may not be reimbursable for them on that side. So they want to keep you happy, go home. So now we're beginning to see a lot of post-surgical studies showing that there's other ways to do it. And then when you go to other countries, and people here have probably been to other countries and seen that their use of opioids is very limited. Usually it's for a very short period of time for those kinds of work-related injuries. And they're also a combination of other pain relievers that you can use besides an opioid. But we became so accustomed to that in the 90s and throughout early 2000s that we never went there. So those are very important issues. And that's where I think internationally we could learn from folks who are in New Zealand doing pain relief for non-cancer pain, et cetera. Yes, ma'am.
Hi, my name is Maya, and I am a PhD student here in Occupational and Environmental Health Sciences. And I've heard you talk about a lot of secondary and tertiary intervention measures, and I'm just wondering what kind of research is NIOSH doing right now that will help us look at how we can prevent these injuries from occurring in the first place, because I see you're mentioning a lot of blue-collar workers, construction industry, agriculture industry. How can we prevent some of these injuries from occurring to help alleviate this problem?
Well, great question, and you're certainly right. All of this stuff is secondary, tertiary, and some of it's a little perverted on the prescribing side. At least it's having perverted effects on a lot of people. I think NIOSH has a long history of doing injury prevention research, decades. And I think if you're available, you might come to the Marriott waterfront tomorrow, because we're having a meeting in which the dean mentioned where injury researchers from all over the United States to do that kind of work to try to prevent the initial injury that leads to the back pain and all of that. NIOSH has a long history of trying to prevent musculoskeletal injuries. It's hard to do because a lot of work requires muscular exertion. So if you're able to, the symposium's going on tomorrow. Okay, thank you very much.
Thank Dr. Howard.
Yep.
And so I know there are many public health students here today. I think this, one of the other things this is intended to do is to give you some information about all the great work that is happening at NIOSH, right here on our campus adjacent to WVU, our School of Public Health. And if you have any interest at all in even visiting or interacting with our colleagues at NIOSH, speak with Dr. Myers. He will get that set up for you, and we look forward to expanding that collaboration. So again, thank you, John. Thank you all for coming.